All right, guys, welcome back to Underground Science. In this video, we'll be talking about Glanzmann Thrombasthenia. Okay, so let's go and get started. So last video, we talked about Bernard-Solier syndrome, right, where we saw a defect in glycoprotein 1b, okay, which affected platelet adhesion, right? Here, this is also autosomal recessive, but the defect is in glycoprotein 2b3a. So we have ineffective platelet aggregation, right? Glycoprotein 1b still is there and functional, but glycoprotein 2b3a is absent or defective. So we do see platelet adhesion because why? Because glycoprotein 1b on the platelets is still functional, right? It's just that you have an absent or defective glycoprotein 2b3a, so platelets cannot aggregate. And remember, this platelet, right, will aggregate with other platelets via glycoprotein 2b, 3a, right? However, so this is also glycoprotein 2b, 3a. But remember, they need something in order to truly aggregate, right? Which is fibrinogen, which connects these two proteins, glycoprotein 2b, 3a proteins. That's how you get platelet aggregation, right? So this is fibrinogen. But if you don't have functional, or if you don't have glycoprotein 2b, 3a at all, right, or defective glycoprotein 2b, 3a, then you won't have proteins, right, receptors in order for fibrinogen to to um to link, right? Because remember, fibrinogen links glycoprotein 2b3a molecules on different platelets. So then you can get platelet aggregation, and that way you can get expansion of the size of your clot, right? So more and more platelets can come to the area where you have endothelial damage, so you don't bleed out, right? But if you can no longer do platelet aggregation, then of course you can expect to see things like increase in bleeding time and things like skin and mucosal bleeding too, right? Okay, so let's go and see what we have next, right? So we know that the main thing about the disease, defective glycoprotein 2b3a, which means you cannot do platelet aggregation. So if you can't have proper platelet aggregation, right, then you can't properly stop bleeding. So you may see things like skin bleeding and mucosal bleeding, right? Like petechiae purpura ecchymosis, mucosal bleeding, like epistaxis, hematuria, hemoptysis, menorrhagia, GI bleeding, and so on, right? And remember in Bernard-Solier, we saw mild thrombocytopenia, but in Glanzmann thrombasthenia, the main problem is in the glycoprotein 2b3a. It's defective and absent due to the autosomal recessive mutation. There's no problem in the platelet count. So your platelet count is normal, okay? Platelet count's normal. You have functional glycoprotein 1b, so you can do normal platelet adhesion, but you just can't do platelet aggregation because you have defective glycoprotein 2b3a. All right, so if we talk about lab findings again, platelet counts normal, blood smear, normal size platelets, right? If you compare this to Bernard-Solier, we saw large platelets, but here we have normal platelet size. Now, because you can't do platelet aggregation properly, it makes sense you would have an elevated bleeding time, right? And remember, ADP, things like ADP, thromboxane A2, if we remember these, right, can make your platelets increased expression of glycoprotein 2b3a, right? Therefore, we say that things like ADP and thromboxane A2 increases platelet aggregation. So it helps make the clot size bigger. And that's why you think you would give things like aspirin to inhibit production of thromboxane A2, right? So you don't make the clot size bigger. All right. So remember, ADP, thromboxane A2 help help induce expression, right, of more glycoprotein 2b3a proteins on the surface of your platelets. So you increase platelet aggregation and make the clot bigger. So that means ADP, things like ADP, right? So ADP stimulates platelet aggregation. Other molecules which we should be familiar with, thrombin stimulates platelet aggregation, collagen stimulates platelet aggregation, and epinephrine stimulates platelet aggregation. Okay, so all of these stimulates platelet aggregation. okay, which is kind of interesting because if you were if you were to give these things in patients with Glanzmann thrombasthenia, right, or Glanzmann thrombasthenia, then you would not see platelet aggregation. Okay, so for example, if you were to do platelet aggregation study, right, and you were to put ADP, thrombin, collagen, epinephrine, right, into the plasma of patients that have Glanzmann thrombasthenia, then you would see no aggregation when you put ADP into the plasma of these patients, no aggregation if you put thrombin into the plasma of these patients, no platelet aggregation if you put collagen, and no platelet aggregation if you put epinephrine. Because all of these things, right, they help induce the expression of glycoprotein 2b3a. But you have an autosomal recessive mutation where you don't produce glycoprotein 2b3a, or you produce defective glycoprotein 2b3a. So even if you give these things, right, you don't have functional glycoprotein 2b3a present on your platelet. So no matter how much you give ADP, thrombin, collagen, epinephrine, right, you can't do platelet aggregation. So you're going to see no aggregation. But if you give ristocetin, right, if you give ristocetin, then that'll be a normal response, right? So ristocetin induced agglutination, right, will be normal, will be present. Why? Because your platelets have functional and normal amounts of glycoprotein 1b. Ristocetin forces von Willebrand factor to bind and agglutinate, right? Which the term agglutination or aggregation here, when talking about the ristocetin test, means von Willebrand factor binding onto glycoprotein 1b. Who does this? Who forces this to happen? Ristocetin. You don't have any problem with glycoprotein 1b. It's you have a problem with glycoprotein 2b3a in this disease. So the ristocetin test would be normal. You would see a ristocetin-induced agglutination. Okay, so that's how you can differentiate from Bernard-Solier syndrome, where you would not see ristocetin-induced agglutination because you have defective glycoprotein 1b in Bernard-Solier syndrome. All right, and yeah, that's basically it. That's the main things to know about Glanzmann thrombasthenia. Um, I hope this video wasn't too confusing. I hope this video helped a little bit. Thank you guys for watching, and see you guys in my future videos.